For those of you who've been to a prior vascular care meeting, many things will look familiar. There are a few things that are a bit different. And for one, you had to find a different meeting room. We've grown, and so we've outstripped the size of the room we were in previously. Each vascular care program emphasizes what we call total vascular care, concept of not only the technical sophistication of care, but the longitudinal care of the vascular patient and the care across the spectrum of professions and disciplines. Because this is meant to be an interprofessional meeting, we reach out to vascular technologists, imaging folks, nurses, and include vascular technologists and nurses as part of our core faculty. This is a meeting that often seems to focus on endovascular therapies, but it balances that with topics of surgical techniques. And this year we're focusing a little bit more on vascular medicine, in part because of some of the feedback that we've had from previous attendees. We hope that the program will provide some broad perspectives addressing not only the state of the art, but what's the current consensus on best practices based on evidence in the medical literature. We also really want to focus upon the concept of taking care of patients across the continuum of care, using complementary imaging modalities, physiologic testing, clinical assessment, considering each individual's problems and the circumstances of their presentation, what they need, and then the long-term follow-up to look at the results of what we do. This, like other vascular care programs, features a multidisciplinary faculty. We hope to provide some guidance on the best uses of endovascular therapeutics and disease management guidelines for patients with vascular disease. There will be some interactive presentations of clinical material. In each of the programs, each of the program days will have panels that will talk about or address some of the issues of the day. And what we'd like to do is get your questions submitted to the panel, and you can write those down and submit those to the CME staff, or you can come up to a microphone that we'll have in the room in the afternoon. We have a breakout session on Wednesday morning for vascular nurses, and we've incorporated educational opportunities for students, residents, and fellows, and I'd like to welcome their participation. The program content is generally clinically focused presentations. Most of the presentations you'll be hearing are relatively short, so we have a rapid to moderate pace, but look for you to interact with the faculty both in the question and answer periods and between sessions. And we've set up the venue and the schedule to allow lots of interaction between the folks who are attending and the folks who are presenting. I mentioned that this is a multidisciplinary program, and if you look at the breakdown of the physicians attending, we have a fairly good mix of vascular and general surgeons, cardiologists and interventional cardiologists, of diagnostic, interventional, and neuroradiologists, and other medical disciplines, internal medicine and others represented. I'd like to welcome our guest faculty. This year we have Dr. Wesley Moore, professor and chair emeritus of the Division of Vascular Surgery at UCLA. A generation of vascular surgeons has grown up going to the Moore course, the annual UCLA review of vascular surgery, which Dr. Moore has provided really as a fundamental part of the curriculum of training of vascular surgeons for a couple of decades now. Dr. Moore is an alumnus of USC, where I went to school, so it's good to have him here. Good to have another Trojan in the room. There's probably two of us. Okay, there we go. We got Krishna Rocha-Singh from Prairie Heart in Springfield. I guess in the Midwest, they don't keep their snow up in the mountains where it's convenient like we do in California, and they have to live with it at inopportune times. I very much appreciate him coming and him participating. Dr. Rocha-Singh is part of the Viva Physician Group and has really been an innovator in many aspects of the care of vascular patients. And I'm happy to have Lou Martin here. Lou is a professor of radiology at Emory. It was in 2001 that I went to Emory to spend some time to learn from Alan Lumsden and Lou Martin and others on the faculty there some of the basics of endovascular techniques that I then incorporated into my practice, and being someone from an era when I trained where 0% of my practice was endovascular to an era now where maybe 80% is endovascular or hybrid. That was an important turning point in my professional development, and I'm glad that Lou's here. We also have tomorrow evening at 8 o'clock the last presentation after the plenary session, a guest presentation from Dr. Neil Van Alphen. Dr. Van Alphen is the Dean of the UC Davis College of Agriculture and Environmental Sciences, and that's the part of UC Davis that really has the kind of control, so to speak, of the new Mondavi Center for Food and Wine. Dr. Van Alphen will talk to us on food, wine, and health, something that I think all of us have either a professional or avocational interest in. And there will be some wine tasting. The last couple of years we've had wines that have been produced by our visiting speakers. Last year Julio Palmas brought some of his wines. Before we had Costa Arger bring some Arger Martucci wines. We do have some UC Davis wine. And we have a very special treat this year, not available in any store, not available not online. We have some John Laird vintage wine. So this is actually quite a treat because even though he's quite humble, it's quite good. We have a number of commercial exhibitors around the corner. You've already seen the exhibit area, and I encourage you to visit the exhibits during the break. We don't have a lot of information about specific devices that we fold into the program from the exhibitor support, but the exhibitors are here in part to provide resources about some of the devices that people are using. It's a good opportunity to hear about new things and to interact with some of the folks who have the technical knowledge about specific products. This morning, we have a particularly long mid-morning break. It's over 30 minutes. Gives you a chance not only to refill your coffee cup and to get another Danish, but it's a chance to visit the exhibits this first day and kind of touch bases with the folks who you're most interested in. It also, for those of you who want to, can go down the hall and get your lift pass if you want to do that. But I think dealing with the folks who are in the exhibit area really provides us with an opportunity to learn about some of the things that are relevant to our practices. The sessions are meant to be interactive. Each day there'll be a panel that will discuss clinical challenges, a review of some of the day's topics, and questions from participants. Case sessions on Wednesday will have an audience response system, and there'll be questions posed to you, and there will be open discussion from the floor. And again, the faculty will be accessible throughout the course. A few bits of housekeeping information. There is a ski race clinic today. This runs from 10 to 2 on the Pioneer Run. You do have to pay for this one. It's $30 and payable at True North, which is the ski shop down the hall. Tomorrow there's a NASTAR ski race. It's open to all participants, and the cost is free to all Vascular Care participants and their guests. And I encourage you to participate. The information about this particular activity is in the blue handout in your folder. For those staying in the village, or those who want to come up here, or those who are staying at the Ritz who want to get down to the village, there's a gondola service that runs from 6:30 to 9. Tonight, for those of you who want to get back to the Ritz, if you go down to the village for dinner, we will be providing a shuttle bus service from 9:30 till 11 p.m. So if you miss the gondola, that doesn't mean you have to hike up the snow. That's a good thing. It's actually even a better thing than having some of the people I know drive back up the hill. CME information. You do need to sign in twice a day. It's a bit onerous, but because we break the sessions up, we do need you to sign in to ensure the correct documentation of your CME hours. And in your packet, there are a couple of yellow forms. One is an explanation of how to use the online system, and another is a form to document your hours and your evaluation of the content. For the way we collect the information, we have online data entry, and you'll be able to enter that information and then print your certificate of attendance. If you want to do that as you go, you can use a laptop on the network here, or there's a cyber cafe around in the near the registration area. And the evaluations that we get from you are really critical to the design of the program. We are very interested in what folks want to hear about, and each year's program is tailored to the not just what we're interested in talking about, what people tell us they're interested in hearing about. And if you say you didn't like the presentation, you won't hear that one again. So we actually take both the positive and the negative and work from there. We're planning already for next year, Vascular Care 2012. We'll move back to the resort at Squaw Creek where we were 2 years ago. This is going to be February 4th through 7th in 2012. You'll see an expanded visiting faculty in vascular medicine, radiology, interventional cardiology, and vascular surgery. It will be in many ways a format consistent with what you've come to expect over the last 5 years, but updated and new material. That's it for my introductory remarks. I'd like to introduce for the morning session chair the newest colleague in the UC Davis Vascular Center, Dr. Willie Chi. Willie came to us, joined the faculty last month, came from Ochsner. And so I'm not sure that he's really acclimated to this type of weather up here in the mountains. It's a little bit different from what it's like in New Orleans. But we're happy to have Willie here as a vascular medicine specialist, not just on our faculty, but on the program to bring some new perspectives. And so I'll turn the morning over to Willie, and I appreciate everyone coming. Thank you very much.
Well, good morning, everyone. I was going to introduce myself, but Dave did a great job. As you could tell, I'm a little bit overdressed. So I was told by Dave to downdress, and I really don't have anything else to wear, but I will try my best. Okay, Dave? All right. As you all know, I'm the newest member, and you could tell I am the newest member. I still have a little jet lag because there's 2-hour difference from New Orleans to Sacramento. But anyways, it is my pleasure to introduce our first speaker, Dave DelPizzo, who is the technical director of our UC Davis International Known Vascular Lab. And I'm going to give the next 15 minutes to Dave, and hopefully we'll hear something exciting and new from him.
All right, thank you. Good morning. You might be wondering how one achieves the honor of presenting first, and I'm also wondering that very same thing, so let me know. I have no disclosures. So I'd like to start with a quick perspective on what are best practices. And it says, the manager says, we'll be adopting best practices in our industry just like everybody else. And the employee says, well, if everybody else is doing it, isn't that the same thing as mediocre? So I guess for our purposes, we need to assume that not everybody's doing it the same. Okay, well, I'd like to talk about 4 main areas that you can put your efforts into to improve the practices in your vascular lab or achieve best practices. So we're going to talk a little about accreditation, your examinations, particularly protocols and reports, credentialing, and then quality assurance. So I put accreditation first because I think this is the most important component of best practices for a vascular lab. And it's also we're going to reference accreditation for quite a bit of this presentation as well. And we know that any accrediting process is a long, painful task with typically unreasonable costs, but we know that there's some benefits being accredited. And for Vascular Lab, it does demonstrate a commitment to quality. ICAVL accredited labs are typically more sought after by your future technologists. You're going to gain more support and exposure to professional societies. And now more than ever, there are links under Medicare carriers for reimbursement. Not every carrier mandates ICAVL accreditation, but there are more states that have this link. So there is definitely an impetus on the reimbursement side. And now we already have over 2,000 accredited vascular labs in the United States. And when we talk about accreditation, I'm referring mostly to ICAVL. This is the most prominent accrediting body for vascular labs. And I put this up here because you can see there are many areas that ICAVL offers that you can be accredited in. The good news is you don't need to be accredited in all these areas to be an accredited lab. You can pick the area that you're doing the most volume. For instance, if you're doing a lot of carotids, you can be accredited lab with that one discipline. And also the first discipline is free with your, where it's included in your fees. So I encourage you, if you are performing high volumes in any one area, that you seek accreditation in that particular region. Okay, protocols. This is typically one of the first areas that managers like to slash, are the protocols to improve efficiency. So it's important to take a look at these. So if you're looking at manipulating or developing your protocols in your lab, I would suggest that you look at that and break it down into 3 areas. And the first is model them after your accreditation. If you are accredited or you're seeking accreditation, you're definitely going to have a template on how to develop your protocols with minimum standards and documentation, techniques, equipment, and so on. The second area to focus on is your documentation requirements. You want to be sure that you have the minimum documentation requirements clearly spelled out, and if they can be as uniform as possible for your interpreting physicians to read the examination. Also, the documentation needs to include methods for your technologists to adapt and extend beyond the minimum requirements so that they capture the abnormalities, unusual anatomy, and also the limitations. We always say take a picture of what you don't see, because that will help paint the picture for the reading physician. And then the last component is the performance of the examination. It's real easy to try to make a very extensive protocol, but it might not be very reasonable to perform it if it takes too long for the technologists, considering you want them to do a good job, improve their optimization, and do it as consistent as possible. So you definitely need to keep that in mind when you develop your protocols. So here's an example of a protocol. This is, again, very consistent, very standard from tech to tech in our department. We're just going to look at a carotid. For your 2D images, the basic format, we do a live clip of the sweep from the common carotid through the bifurcation, and also a still image. We have a long axis of the common carotid, the external and the internal. And then for the spectral Doppler analysis, we take 2 points in the common carotid artery, proximally and distally, external carotid artery, and then 3 measurements in the internal carotid artery. 3 points, the proximal, mid, and distal segments. The vertebral, the subclavian artery, and again, any more information that's going to help with the interpretation of the exam, unusual anatomy, clearly your pathology, and any limitations. So again, very consistent and streamlined for the reading physician. Then all of this information has got to go into a report. So I like to break the report down again into 3 areas, and the heading of the report, or the beginning of the report, that's going to consist of your demographics, your indications, and your methods. Then the body of the report, typically this is often compiled by the technologist, a clear description of the findings, refraining from using diagnostic terms, and then down to the interpretation. This is where the medical staff is going to provide the diagnosis, summarize the findings in a clear fashion, and add the value with the diagnosis. So an example of a report, beginning of the report, clearly we'd have the patient information, we have the title of the exam, and then the relevant indication and clinical data, why we're doing the examination. You need to have a component of the report that describes what you're doing, or the methods, what you're using, and how. And then the bulk of the report. This is where all the findings are going to be provided. Description of the plaque, description of the peak systolic velocities. Again, just descriptions, not using the diagnosis. And then all this information needs to be applied to an agreed upon classification for disease by the medical staff, so everybody uses the same criteria for rendering an impression. And that's the last part of the examination, is the interpretation. So again, a clear, concise interpretation using the diagnoses in a summary fashion. Now we know that this is often, the impression's often the only part of the report that's looked at by referring physicians. So it's important to have some form of requirements for your interpreting physicians. And I have 3 listed here, but the 4th one is the most important, and it's not spelled out, but one of the requirements we have is that our medical staff must be attractive, and if they're not, they're just not part of the deal. So the other 3 are important, but not as important. The report needs to be clear and concise so that everybody sticks to the same criteria. We don't want to have a velocity interpreted in two different ways depending on who's reading. It does need to be time sensitive, date and time documented. It needs to be turned around with a certain point of time. ICAVL requires 48 business hours. And then again, it needs to add value. It has to differ from the preliminary report, provide the diagnosis, and then also this is a place where they can maybe correlate the exam findings with the indications. So if there was referred for a bruit and there was tortuosity that was providing high elevated velocities but everything else was normal, they may say that so that they can see what might be the source of the bruit. The credentialing, we're going to talk about two credentials from the ARDMS. One is the RPVI. This is specific for the medical staff. Must be a physician to sit for this exam. It's relatively new, came out in 2006. It does suggest a minimum competency in interpreting non-invasive vascular studies, but far and large it is relatively voluntary. There are no links to reimbursement. It's pretty much lab specific. But it depends on who you are, because starting in 2014, it will be a prerequisite for any vascular surgery fellows that are going to be taking the vascular surgery qualifying exam, so that voluntary to a degree. But nonetheless, we require RPVI credential for our medical staff, and each of them are. And then the second one, as we all know, is the credential for the technologist, the RVT. And again, this is more or less voluntary as far as state mandates. There really are none. There are a few states that require credentials for reimbursement, but most of them do not still. But I think that the drive is leaning more towards that way, especially with accreditation going that way. This is the registered vascular technologist, demonstrates a minimum competency of your techs. They're required to do acquire CMEs every year. So I would encourage both medical and technical staff to be credentialed. And then the last area is quality assurance. I seem to like groups of three here. Break this down into three. You need to have some mechanism of measuring the quality with your examinations. Again, if you're accredited, they're going to spell it out for you and give you requirements. In our department, we sort of have three areas that we try to keep our quality assurance up. One is simply a review. We try to do a daily peer review of our examinations. The billing department looks at our exams, and we're trying to capture any blatant mistakes that may go out before they actually get to the interpreting medical staff. So any laterality errors or an annotation error to that effect we'll try to correct right off the bat the same day. But the meat of this is you have to be comparing your examinations to a gold standard or something a little bit more definitive, angiography, CTA, surgical findings. And then have regular meetings where you can compare these. So your CQI officer will have to prepare QA meetings so that you can review your correlations, discuss your discrepancies, and try to continually improve your accuracy. So these are just some examples of correlating our duplex exams with other modalities. Here's an ICA thrombus and ICA fibromuscular dysplasia. And here is an acute ICA occlusion. So I would say for best practices in the vascular lab, you want to always have good practices with all components, but I'd say it begins with these four areas. I would recommend that you get accredited if you aren't, at least in the discipline that you're doing the most volume of your examinations. For examination purposes, focus on your protocols and reporting. I would encourage credentials from both your medical and technical staff, and you also need to develop a mechanism to compare your exams for quality assurance purposes. Now, just to show my loyalties, this does demonstrate that I was well on time of preparing my talk for the CME office, a little bit premature, so next year. Thank you.
We still have a couple of minutes, but I was going to ask Dave the question that I could see the number 4, the most important criteria about being attractive as part of the panel, and I was looking at it. There are 4 pictures, and I'm not one of them. So is that a hint that I need to visit my plastic surgeon in the next couple of weeks or so?
Most of the presentations you'll be hearing are relatively short, so we have a rapid to moderate pace, but look for you to interact with the faculty both in the question and answer periods and between sessions. And we've set up the venue and the schedule to allow lots of interaction between the folks who are attending and the folks who are presenting. I mentioned that this is a multidisciplinary program, and if you look at the breakdown of the physicians attending, we have a fairly good mix of vascular and general surgeons, cardiologists and interventional cardiologists, of diagnostic, interventional, and neuroradiologists, and other medical disciplines, internal medicine and others represented. I'd like to welcome our guest faculty. This year we have Dr. Wesley Moore, Professor and Chair Emeritus of the Division of Vascular Surgery at UCLA, and include vascular technologists and nurses as part of our core faculty. This is a meeting that often seems to focus on endovascular therapies, but it balances that with topics of surgical techniques. And this year we're focusing a little bit more on vascular medicine, in part because of some of the feedback that we've had from previous attendees. We hope that the program will provide some broad perspectives addressing not only the state of the art, but what's the current consensus on best practices based on evidence in the medical literature. We also really want to focus upon the concept of taking care of patients across the continuum of care, using complementary imaging modalities, physiologic testing, clinical assessment, considering each individual's problems and the circumstances of their presentation, what they need, and then the long-term follow-up to look at the results of what we do. This, like other vascular care programs, features a multidisciplinary faculty. We hope to provide some guidance on the best uses of endovascular therapeutics and disease management guidelines for patients with vascular disease. There will be some interactive presentations of clinical material. In each of the programs, each of the program days will have panels that will talk about or address some of the issues of the day. And what we'd like to do is get your questions submitted to the panel, and you can write those down and submit those to the CME staff, or you can come up to the microphone that we'll have in the room in the afternoon. We have a breakout session on Wednesday morning for vascular nurses, and we've incorporated educational opportunities for students, residents, and fellows, and I'd like to welcome their participation. The program content is generally clinically focused presentations. For those of you who've been to a prior vascular care meeting, many things will look familiar. There are a few things that are a bit different. And for one, you had to find a different meeting room. We've grown, and so we've outstripped the size of the room we were in previously. Each vascular care program emphasizes what we call total vascular care, concept of not only the technical sophistication of care, but the longitudinal care of the vascular patient and the care across the spectrum of professions and disciplines. Because this is meant to be an interprofessional meeting, we reach out to vascular technologists, imaging folks, nurses. A generation of vascular surgeons has grown up going to the Moore course, the annual UCLA review of vascular surgery, which Dr. Moore has provided really as a fundamental part of the curriculum of training of vascular surgeons for a couple of decades now. Dr. Moore is an alumnus of USC, where I went to school, so it's good to have him here. Good to have another Trojan in the room. There's probably two of us. Okay, there we go. We got Krishna Rocha-Singh from Prairie Heart in Springfield. I guess in the Midwest, they don't keep their snow up in the mountains where it's convenient like we do in California, and they have to live with it at inopportune times. I very much appreciate him coming and him participating. Dr. Rocha-Singh is part of the Viva Physician Group and has really been an innovator in many aspects of the care of vascular patients. And I'm happy to have